Hello, welcome back to another 3D echo on substance use disorders. I see Dr. Horn has joined us. Hello. Let's start off with a round of introductions. I'm Dr. Bob Seiss, addiction psychiatrist with Frontier Psychiatry. Let's keep going around the hub.
Amber Rogers with Mountain Pacific.
Mary Argonis with Mountain Pacific.
I'm Malcolm Horn with Rimrock Foundation.
Mark Marbella, Mountain Pacific.
Kimberly
Excellent.
Hill, Kimberly Hill with Ideal Option.
Welcome, Kimberly. Looks like Maynette Wong is also on.
And then how about if we introduce Sharon and then Jennifer?
Yes.
This is Jennifer Quinn from Logan Health.
Welcome.
How about Sharon and Jessica next?
Sharon Christensen from Butterfly Homes.
And I'm Jessica with Mountain Pacific.
And then I believe we also have Tony King from our Medicaid drug utilization review.
Indeed, Tony King, pharmacist with Mountain Pacific.
Excellent. Welcome, everyone. Let's get this going. 1 second here. I'm doing a dueling computer setup today, and you'll let me know how it goes. All right. Today we'll discuss substance-induced psychosis. Please sign in using the link provided in the chat box that Amber potentially, I don't have the chat box open, but potentially it's already shown. If not, it's going to be there in a heartbeat. You'll get 1 hour of continuing education. So Doctors Eric Arzubi, Reza Hosseini Gomi, and myself are all owners and co-founders of Frontier Psychiatry. Dr. Hosseini Gomi, as well as Amber Rogers, do have these commercial interests that are laid out here. The staff at Mountain Pacific will ensure that this entire presentation remains free from any sort of commercial interest. What announcements do we have, Amber?
I do not have any off the top of my head. Anybody else?
All right, let's get started. Today, we will review the diagnostic criteria for substance-induced psychosis, discuss how to differentiate between primary and substance-induced psychosis, talk about implicated substances of abuse, highlighting methamphetamine as well as cannabis, talk about treatment, and close with takeaways. Psychosis in general describes gross impairment of reality testing. The core symptoms many of us are familiar with: hallucinations, both auditory as well as visual, in some cases tactile, delusions, disorganized thinking and speech, disorganized behavior, negative symptoms such as flat affect, social withdrawal, decrease in overall function, and cognitive deficits. The functional impairments associated with psychosis impact relationships, work, education, and activities of daily living. Substance-induced psychosis, per the DSM, has to have the presence of delusions and/or hallucinations during or soon after intoxication and/or exposure or withdrawal from a substance. The disturbance can't be better explained by another type of psychotic disorder, nor can the disturbance occur exclusively during the course of a delirium. And it needs to cause significant distress or impairment in function. Withdrawal from substances that is commonly associated with psychosis in extreme circumstances, alcohol as well as benzodiazepines. Intoxication on amphetamines and methamphetamine, as well as other stimulants like cocaine, hallucinogens, PCP, inhalants, cannabis, and bath salts can all result in psychosis. Prescribed medications, including steroids, dopamine agonists like levodopa, stimulants. The implicated pathophysiology is similar to what we have in primary psychosis. Specifically, you get overactivation of the dopamine pathway. The brain's dopamine pathway can be thought of as a salience machine. Dopamine helps us discern what is important and what is real from that which isn't. Simply put, it lets us know what's coming from the outside of us versus what's coming from the inside. All of us right now have internal dialogues going on. We may be thinking about what we had for lunch, what we want to do, what we'd rather be doing other than attending this clinic. But we're able to discriminate between that and this conversation. And dopamine is the principal neurotransmitter that facilitates that. Any of these substances, from alcohol to anabolic steroids, analgesics, anticholinergics, antidepressants, antiepileptics, going down the list, hallucinogens, inhalants, interferon, over-the-counter medications, including dextromethorphan, some stimulants and toxins, all of these, especially when they're used in excess, can cause malfunction in the dopamine pathway, disrupting our brain's ability to discern that which is salient from that which isn't. Imagine if your internal dialogue all of a sudden took on the same importance as everything that you heard being said around you in your environment. It'd be really confusing and terrifying. So how can we tell the difference between a primary psychosis versus substance-induced psychosis? Oftentimes there's a distinct presentation. In the case of withdrawal and alcohol withdrawal, alcoholic hallucinosis tends to happen really about 48 hours out from the last drink. In benzodiazepines, similarly, you can have it in withdrawal. Visual hallucinations are way more common in methamphetamine intoxication, whereas tactile hallucinations are more common in alcohol and benzo withdrawal. The positive symptoms often predominate. When we say positive symptoms, we're talking about hallucinations, paranoia, delusions. And oftentimes there's a lack of negative symptoms. The social withdrawal, the flattened affect. We don't see that in meth-induced psychosis, for example. Chronic use can shift the presentation. Specifically, psychosis and chronic meth abuse tends to look a lot like schizophrenia, though normally there's lack of negative symptoms. The similarity comes in that if somebody uses methamphetamine on a daily basis for long enough, the brain's dopamine pathways shift so radically that oftentimes these individuals will continue to have hallucinations and delusions well into abstinence from meth. The course of illness matters here. We can't diagnose primary psychosis unless the symptoms persist at least 1 month into abstinence. There is an exception again for chronic meth abuse. Higher suspicion for substance-induced versus primary psychosis if the onset of symptoms coincide with a substance use intoxication or withdrawal. And it's worth noting that substance-induced psychosis can transition to primary psychosis. Specifically, in one study, they saw a quarter of substance-induced psychosis progress to have a diagnosis of schizophrenia, which makes us wonder in these cases, in the quarter of cases where this happens, did exposure to a dopaminergic substance hasten the progression of schizophrenia? In other words, if through a primary process, the dopamine pathways were going to get out of whack regardless, did exposure to, say, methamphetamine just hasten that process? Focusing on methamphetamine, it is quite common. There are about 1.6 million users last year. It's an explosive psychostimulant with dual mechanism of action. As we saw in the last echo, methamphetamine both displaces catecholamines, epinephrine, norepinephrine, and dopamine from inside neurons into the synapses, and then it blocks the reuptake of these neurotransmitters from the synaptic cleft. Highly dopaminergic. And with this increased activation of the dopamine pathway, you get hallucinations and delusions, and it's worsened with higher frequency of use and higher doses. Focusing on cannabis, there's, of course, a wide variety of cannabis-based products available, offering varying concentrations of cannabinoids. There are 85 different cannabinoids within cannabis sativa, yet there are two that we're principally concerned with, and they're in the greatest abundance: cannabidiol, CBD, and delta-9 tetrahydrocannabinol, THC. Various different strains of cannabis exist, offering relatively different concentrations of CBD versus THC. THC is a CB1 receptor agonist. It's psychoactive, resulting in altered mood, cognition, and in some cases, especially at higher doses, more frequent use, hallucinations. Whereas CBD is an indirect CB1 and CB2 receptor antagonist, may have immunologic and anti-inflammatory effects, may even act as a low potency antipsychotic. Yet it is worth highlighting that across all strains of cannabis sold in the US over this 20-year interval from 95 to 2014, if you're to look in recent years, this trend would continue. You are seeing across the board an increase in THC concentration in all strains, be it recreational or medicinal. People are getting more and more THC product. You can smoke it, you can eat it, you can use it in concentrates, butane hash oil. Oh, my pictures of this disappeared. These concentrates are remarkably potent. And in some cases, you can get the equivalent of what many people would regard the common joint, 20-fold that in the case of wax and shatter. There's a strong association between cannabis use and schizophrenia. In a cross-sectional study, they saw regular cannabis use was associated with 2 to 3 times higher lifetime prevalence of schizophrenia compared with non-users, strongly associated with earlier age of onset of use, higher frequency of use and amount used, and use of products with high THC to CBD ratios. In a systematic review that included 53 studies of patients with schizophrenia spectrum disorders, so essentially primary psychosis, almost a quarter had used cannabis over the past 6 months, and over 40% had a lifetime prevalence of cannabis use. So strong association. In particular, I want to highlight that earlier age of onset of use showed an even stronger association. Could it be that cannabis use, especially in adolescence, given it impacts the dopamine pathways, is in somehow increasing the risk of subsequent pathophysiology within those pathways, resulting in psychosis? It's also associated with higher THC concentrations. Case studies demonstrate there's a general association between the use of high-dose THC products like wax and cannabis-induced psychosis. It's well documented that acute THC administration causes increased dopamine release. Again, going back to the dopamine pathway, when it is hyperactivated, things get out of whack, and the salient system doesn't work well. People have a hard time telling that which is real from that which isn't. It remains unclear, though, if this acute effect is related to the development of schizophrenia associated with chronic cannabis use. That said, though, in a Danish study that used a national registry of about 1,500 patients who were diagnosed with cannabis-induced psychosis over a 20-year interval and followed them, it found there was a 41.2% conversion to schizophrenia. In another study, it was a systematic review of 35 longitudinal studies, there's an increased risk of psychosis associated with any lifetime use of cannabis and a dose-response relationship, 2 times increase in risk among the highest frequency users. Finally, in a Finnish prospective longitudinal study, they saw a significant increase in the risk of psychosis among subjects who use cannabis more than or equal to 5 times by the age of 16 years old versus those who never used. So again, we see it's especially concerning when adolescents, younger than 16 years of age, use cannabis over 4 times, there is a higher lifetime prevalence of psychosis. THC does worsen positive symptoms. In a systematic review meta-analysis of 24 longitudinal studies that had over 16,000 participants, the authors saw that cannabis use was associated with increased relapse, rehospitalization, and more positive symptoms. And the relapse here is recurrence of psychosis. Cannabis use was also associated with poor overall level of functioning. In a 2-year-long prospective longitudinal study of over 200 adults with first episode psychosis, they saw an increased risk of a recurrence of psychotic symptoms resulting in hospitalization during periods of cannabis use. Suffice it to say, if someone has primary psychosis and some degree of kind of endogenous hyperactivation of the dopamine pathways, adding THC makes it worse. The treatment of substance-induced psychosis is really driven by the severity of symptoms and the underlying cause. We always need to treat medically if it's related to substance withdrawal. And the core examples here are alcohol and benzodiazepines. In that case, oftentimes we're going to treat with GABAergic medications to help restore the balance between GABA and glutamate, as it's relative glutamate excess that drives withdrawal. And treating that can restore equilibrium, oftentimes resolving the psychosis. And we need to ensure the appropriate level of care depending on the level of severity of the psychosis. If somebody has fulminant meth-induced psychosis, they should go to the emergency department. And oftentimes we'll treat with either haloperidol or second-generation antipsychotic like olanzapine. We do have to be wary of hemodynamic instability, a fall in blood pressure, in the case of meth-induced psychosis when we treat with an antipsychotic. But generally, in the inpatient setting, we can proceed to do this, continue to monitor. Most patients don't experience it. The takeaways. The time course and presence of negative symptoms help us differentiate between primary versus substance-induced psychosis. Methamphetamine has a remarkably high likelihood of inducing psychosis, and chronic use can result in long-lasting psychotic symptoms well into abstinence. In the case of cannabis, high THC consumption is associated with both acute psychosis and an increased lifetime risk of psychotic disorder. It's especially associated with worse positive symptoms, and there is some, albeit weak, evidence suggesting a causal link and a potential change in dopamine pathways. How can we communicate this to patients? Would like to open it up to folks. And if I may ask for a little help from Dr. Horn.
Help with what? How do we convince
What do you,
people
yeah, what do you
smoking pot
tell
is
your
bad and
patients?
can lead to psychosis? Like, yeah, that is the $1 million question. That's certainly something that we see where we know that there's the research, we know that there's the data, and trying to use a lot of motivational interviewing to help, I want to say, convince patients that, hey, if you want to avoid psychosis, you should probably also avoid pot. And that is a huge challenge because they don't see it as being harmful. So I don't know, I'd love to hear from anybody else what you do. It's hard. It's really hard. And we actually just had a discussion in our leadership group earlier this week about the vape pens, because people, okay, so I can't smoke cigarettes. So they all walk around with vape pens around their neck. And who knows what they actually have in there? Do they have a THC cartridge in there? And trying to tell some of our patients, particularly those that already struggle with mental health issues, that, hey, I know that your cigarette or your joint relaxes you and takes away some of your anxiety, but I'm worried that that's not a great choice for you. That's a hard conversation to have. They don't want to hear it. So I'd like to hear what other people are doing, because me, it's hard. I've tried to say, let's go to the website for the National Institute of Drug Abuse. Let's pull up Dr. Seiss's PowerPoint and let's talk about it. Well, he doesn't know, right? Well, I'm pretty sure Dr. Seiss probably actually has more smarts than you about this, but it's hard. And in some ways I try to just validate, okay, I understand that this gives you something to feel like you have control. This helps you relax. This helps you whatever. Let's look at some alternatives so you have other options besides just smoking the pot. So.
And there's a dynamic of motivational interviewing.
Yep.
You acknowledge the ambivalence.
Yep.
And really try and engage the dialectic of cannabis
Absolutely.
in the moment. How about kind of the next day? Do you find that you're more anxious, more apt to worry about things you normally wouldn't worry about, and at times have
Absolutely
really altered interpretations of what's happening?
I have one patient right now who uses edibles nightly. And he also has major depressive disorder and generalized anxiety disorder. And, you know, we were having this conversation where he says, well, you know, I use the edibles, they help me sleep. And almost every session, because sleep is an ongoing issue for him, I said to him, so how, you look tired. Are you sleeping? No, I'm not sleeping. It took me hours to go to sleep. And I said, I'm wondering if maybe the edibles aren't working. Maybe try not having the edibles. But I actually kind of like the way they make me feel. Okay, so you're not actually using the edibles to help you sleep. You're using the edibles because you like the way they make you feel. Okay, right? So having a real honest discussion about it. And again, you're a grown adult. If that's what you choose to do, I can't stop you. I would like to think, though, we can have a discussion about alternatives, other ways to feel good, other ways to feel better, because we all want to feel better, right? That's the common thing. None of us like to be uncomfortable. So how can I help you find other ways to feel good? So we'll see. I think that we should have public service announcements, right? We had the meth campaign, the Not Only Once campaign. You had billboards, you had commercials about meth, not even once. I feel like we need to start doing that for cannabis, particularly the topic today was the psychosis. I think that people don't understand how truly dangerous the THC can be, particularly if they already have an underlying psychotic issue. So I don't know if that means we need to rally together and say, we need to have some public service campaigns so people understand if they're still going to use the pot, at least they're making an informed choice.
Couldn't agree more. What's really concerning is you go into head shops, for example, Washington, Colorado, and increasingly available are the concentrates, in some cases, the hyper concentrates. And in the case of dabbing or using wax, shatter, in some cases, people are getting 100 milligrams of THC a day, which again, if there is such a thing as a common joint, that's 5 milligrams.
Right.
So when I was in training at UW Harborview, there was a Seattle University college student, 20. This would have been in 2015. So recreational cannabis was very legal, very available. He ended up enucleating himself during a psychotic episode. He took out one of his eyes. It was really tough.
Oh my gosh.
And he basically, at least during the few months that he was kind of coming in for care and we were able to talk about him in case conference, he continued to be psychotic. And of course, it begged the question, was this somebody who was going to go on to develop primary psychosis, schizophrenia, regardless, or was this THC induced?
Right.
Or perhaps, did THC exposure in mass somehow hasten the onset of primary psychosis?
Right. Well, especially when you take into epigenetics, did, like, to your point, did he have a genetic predisposition and that his vulnerability was there and that.
Right, exactly.
So this is Amber. I hate to admit how dumb I am, but I don't even know what wax is and I don't even know what dabbing is.
Yeah, so all of it deals with, they're essentially concentrates derived from cannabis, oftentimes in oil, that people can smoke. Seeing someone smoke a concentrate, it's probably going to look more akin to someone smoking crack, especially in the case of glass or shatter, than it is watching somebody smoke a joint, for example. And the significance of it is this is a THC hyper concentrate, about 20-fold as potent in THC as a joint.
Yeah. And there are, I'm looking on my screen right now. I can put some in the, mute myself, sorry.
You're going to show us some
Yeah, here you go. I'm
Example
just putting
use?
in the link.
Yeah,
Hold
share
on.
that
Yeah, I'm like,
screen.
mute
Or
myself.
feel
So
free to
here's a-
share if you'd like.
Oh, I could do that. I just put in the link. But there are, if you go to YouTube, there are a ton of videos on people dabbing, doing all these things. And for one thing, as a parent, it kind of scares me to death because my kids love YouTube. They love finding all the things. But it is a common thing out there. And I think that when we talk about evidence-based care, how do we do treatment? I think as clinicians, we have to be aware of this is what they're watching, this is what they're seeing. And so this is part of their norm, that this is something you can do. So I just put like one sample in, but there are a ton of videos and I recommend that you watch a few to see, oh, that's what they're doing. And I think that then we can open that conversation to saying to them, do you, I don't know how to word this. Not that you would say, well, do you think that's a smart thing to do? But I mean, if you talk to, kids, I'll say, okay, smoking cigarettes, good or bad? Like, oh, bad, causes cancer, bad. Like they all know smoking cigarettes are bad. Okay, smoking pot. Oh, it's natural, it's fine. Because they watch videos like this, or it's cool, right? We do the dabs, we do the showers, it's cool, it's part of the club. And so I think we have to have those conversations to say, well, you know what? A few decades ago, people said smoking cigarettes were cool. That was a cool thing, it was innocuous. And now we know that is not the case. And I think we'll see the exact same thing happen with cannabis. We'll be like, oh yeah, we were not smart in doing that. But anyway.
So
Great points. And what we're seeing time and time again, it's especially concerning when you see the onset of use early on in adolescence. So the brain does not complete maturation till age 25. And the more people can delay onset of cannabis use, especially high THC content product, the less the likelihood it's going to somehow provoke long-term psychosis.
It's a little off topic, but more maybe politically looking at. So Ben Court is from Colorado. He has a TED Talk that talks about the commercialization of THC, and he talks about, we didn't really legalize it, we commercialized it. And he makes some really good points. He has a book called Weed Inc. Good book, not super heavy, hard to read, but he makes some really good points. And I think he carries more weight than most of us because he's also in recovery. He's a 12-stepper. And so when he talks to people, patients that we work with, he knows the lingo. Two, he has street cred because he's like, I know exactly what we're talking about. And so I think that we have to be able to access videos, books, things like that to give patients and say, you know what, because obviously I don't know what I'm talking about, but here is someone who does, here's some resources, and let them, again, that goes back to some of that motivational interviewing. Let me give you information, you explore it, you talk about it, and then let's decide what's best for you. Let's make a decision about your treatment and your course of care that is in line with what they know. So.
Yeah, and that's very compelling. And sure enough, talk about the commercialization. You don't have to look too far, trace the money. Philip Morris has bought up a chain of dispensaries, a Seattle-based chain of dispensaries, as they see the market potential.
Yeah, absolutely. Right. So.
Hi, it's Clarissa Juarez.
Hi,
Can you
Clarissa.
hear me?
Thanks for joining
Hi.
us.
Yes,
Good to hear
I'm
your
here in
voice.
New Mexico this week.
All right. Do you have a camera? Do we get to see you?
You know what? I don't know if I was trying to get my camera on. So,
Okay.
but anyway.
We'll have to settle for voice.
Yes, you will. One of these days. I have my desktop coming soon. So hopefully.
Clarissa and I coincided at Billings Clinic. I really enjoyed working with her. It's awesome that you're able to make it.
Yes, thank you. I enjoy these. One of the things I was thinking about when you were talking specifically about schizophrenia and how we work with patients and the positive symptoms is that I've had a lot of cases where there seems to be this catch-22, right? So the worse my voices are, the higher my anxiety is, the more pot I smoke because that's what helps my anxiety. And so sometimes I've been able to get a little bit of a niche in through family. For example, I had one particular patient in Western New Mexico whose mom would come in with him every every appointment, and she was the biggest advocate for him for smoking pot, right? For using marijuana, because she said, yes, it helps his anxiety and his voices are bad. So what I asked mom to do, well, first of all, I asked if they would be willing for us to try alternative ways of managing the anxiety with, with other medication, or we try to get him in with therapy, but that was difficult. Had a great therapist that would work with him, but he didn't really show up a lot or stick with it. So I asked mom if she would keep a log at home, because she would be the one to me complaining about his voices are bad. His voices are bad. He's talking to himself all the time. He's wandering in the night, these kinds of things. So I asked mom if she would keep a log of kind of corresponding with his positive symptoms and his pot use, right? Versus as we brought in some medication and better manage the anxiety, right? And did that affect his voices, and was he able to cut back somewhat on the marijuana use? And so did he notice that improved the positive symptoms? So it was, in that case, a successful outcome. Not always, but it was just interesting because I couldn't, of course, I was suspicious about what was causing what, and how the THC was probably worsening his auditory hallucinations. But at that point, they just weren't willing to consider that the marijuana, was doing anything other than helping his anxiety. So it's a really difficult problem to address in that population.
A very challenging dynamic. That's a great example of one of the misperceptions we so often run into. And Dr. Horn, you emphasized it just a moment ago, that cannabis is somehow benign. When we know in the case of psychosis, it's going to worsen the psychotic symptoms and oftentimes complicate treatment. It's remarkable how in covering emergency departments through my work with Frontier, I've seen some patients who are even in group homes affiliated with mental health centers, those who have quote unquote green cards or quote unquote medicinal use of cannabis are able to consume cannabis at those group homes. In particular, treated a patient who has primary psychosis and was able to continue to consume cannabis on a daily basis along with their antipsychotics. And it makes, it prompts a lot of concerns and questions about what we're doing from a policy standpoint, and the role of quote unquote medical cannabis. Any cases, any more patient examples, questions? Do we want to watch YouTube videos together?
Yeah, you can. I put another one in the chat box. You could pull that up and share the video.
Excellent. Yeah.
I think part of the problem too is it's so hard when, I've never smoked pot. I have no idea, but I'm told it really relaxes you. And so it's hard to argue when they see this huge benefit, that maybe is better, it works better than other drugs. And so letting them know, yeah, that is a valid benefit of it. What I try to tell patients is if you're going to think about it medical, you should have a whole list of side effects, right? If you go to the pharmacy and you fill your Seroquel or whatever, you get a whole list of the potential side effects. You go to the pot shop, you don't get that. And so I try to tell patients that, okay, if there's going to be a benefit, you need to look at the side effects as well. There we go.
Right. The plan. So this is shatter. I'll rewind it to the beginning. And Dr. Horn, what are you seeing at Rimrock when it comes to, here we'll go all the way from the beginning, when it comes to use? What are the kids talking about? Kids, as obviously people in their 20s and 30s.
They talk about it makes them feel good. It makes them feel like they fit in. It makes them feel cool. And again, I can't necessarily, okay, so this one, the butane hash oil, that is, I mean, it's butane. You are consuming something that has been soaked in butane, right? How healthy is that for you? Ooh. Anyway, so they talk about it makes them feel good. And I say, okay, I'm glad it makes you feel good. And so what else can you do to help you feel good? And I want them to have the ability to say, yes, it makes you feel good. Are there consequences as well? And before it was legal recreationally, you know, we could say, well, it's still illegal. Yes, it makes you feel good, but hey, there's a consequence. It's illegal. Now that essentially is gone. I can no longer use that argument. So I have to go back to, there's lots of things that are really good for you. Is that real? I mean, there's a running joke here at my office that peanut butter M&Ms are my crack cocaine. Those are my drug of choice. They are tasty and I love them, right? But I don't want to eat the whole bag. If I eat the whole bag, I'm going to have a negative side effect. I'm going to have a stomach ache. I'm not going to feel very good. So yes, I can enjoy it, but I have to recognize there's a consequence. And so really trying to get people to be open to that there might be a consequence, that it might not be the most wonderful thing ever. And I think just even having that discussion, because what I have found is that when you tell someone, no, don't do that, it's not good for you, they're like, huh, watch this, game on. So if I can say, okay, you can still choose that. Like, I'm not your parent. I'm not going to tell you no. I want you to make an informed decision. Then that gives them a little bit more willingness to really look at both sides. And again, because at the end of the day, for any of us, we can't fix our patients. Our job is to help them. Our job is to help and guide them and help them to make good informed decisions for their own health and well-being. So that's the tack I have to take. Get education, get insight, and what they choose to do with it is up to them.
Like it, and perhaps the contrast in the latter scenario in which you're posing them the option and talking about the risks, maybe even to a certain extent the benefits insofar as decreased anxiety in the moment.
Sure.
You're sitting with the patient, you're collaborating with them,
Right?
sitting in with them alongside their ambivalence about a substance. Where in the first scenario, when you say don't do this, you're against the patient. It's
Right.
1950s medicine that we know don't work.
Mhm.
Nancy Reagan, just say no.
Say no.
So this is Amber, and we have a pharmacy program here in Missoula, and they have a very active student pharmacy group that attends our Missoula prescription drug coalition that we have here. And one of the members in particular took this little project underneath her mantle, and she routinely visited with a particular high school. And she started when she was at the beginning of pharmacy school, and she got more skilled at motivational interviewing and talking to patients, because this was kind of a clinical experience too. But she talked to the same group of kids when they were freshman, sophomore, junior, and senior. And she talked specifically about marijuana usage. She doesn't have any stats. She doesn't, and she changed her message over time. But I'm really thinking that youth engagement with somebody that does not look like they're 55 years old, somebody that still looks, youngish and isn't necessarily in that position of power yet, she not only did she feel like she gained as a professional, gained that experience in talking to that group, but that she was also somewhat able to relate as a peer, because she wasn't that far out of high school herself. And I think really getting those kids to understand, I like the idea of side effects, but I don't know if that always resonates with a population that you're trying to delay that gratification. Wait till you're at least 25.
Well, and your point too, do kids see that? Their feedback, sorry, right? Because they may not see that. Like, that's not going to happen to me. Yeah, I don't have to wear my seatbelt. I'm not going to get in the car crash. I mean, adolescents by nature don't necessarily do that forward thinking very well. And so, yeah, they'd be like, yeah, you're 50 something. What do you know? Like, you may say that, it's not going to happen to me. And so, yeah, when a younger person absolutely can better align with them and maybe have some more ability to get through to them. It's not it's if you think go to group thinking, if you're the adult you're the outside my group. You're not in my group. Versus if it's someone in my group, oh, I might align more with you because you're in my group. So, yeah.
We need compelling interventions as use among adolescents is going to increase significantly. It happened in Colorado. It happened in Washington. Even though cannabis isn't intended for the adolescent market, there's going to be spillover. They saw it in both of those experiments, and it's going to happen here too.
I also wonder if, as part of any kind of a family intervention, whether that be child and family services with meth being a primary reason why kids are taken away, that same education, whether it be to the grandparents and to the kids if they're old enough, to somewhat understand and craft that message about, you're at risk now because you have that genetic. I mean, I don't know how to break through that adolescent brain, because I probably would have poo-pooed somebody too, but live and learn.
I think one of the things that I've said to patients, like, okay, so you smoke pot. What would happen if you didn't? What would happen if you stopped? Like, what would that look like? Would you want to do it? Like, if I dared you, like, challenge accepted, all right, to go for a week, can you do it? And if they can't or are very resistant to doing it, then I get to pull up then I'm not so sure that you're actually consciously choosing to smoke the pot, because if you're going to accept my, like, oh yeah, I can go without it, but then you actually can't, or you get resistant to it, that tells me that it's more than just your choice. There might even be that word addiction in there, where you're really not in control. Because I see that with adolescents, and that's a stage for adolescents, right? They should be going through a stage of growth and development and individuality where they do want to have control. I want to be my own person. So if I could point out that, oh, wow, maybe you're not really in as much control as you think you are, that again gives them another way to think, like, oh, maybe I'm not. Right. So, and a lot of people, addiction starts off about power and control. I need a way to feel like I'm in control. I need a way to feel like I have power over something. And so if we can gently point out that maybe you're not in as much control as you think, right? Then that gives them another way to consider that, okay, maybe I'm not in as much control. And if Malcolm has done her job and made this a safe place for me to explore those uncomfortable feelings or that ambivalence, then maybe Malcolm will help talk to me about what things I could do to feel more empowered in my life. Because if I'm constantly seeking the drug or the whatever, then I'm probably not in as much control as I think I am. And so as clinicians, if we've made it a safe place for patients to explore that ambivalence, then they're open to our suggestions. So sometimes that's a long process, though. That can take weeks, if not months. So that's another strategy, so to speak.
Seen a lot of black screens.
I know everyone's quiet. I had to do lectures earlier today too for the main facility, and everyone was quiet there too. So I don't know if it's the rain. It got cold and rainy, and everyone is just like, not talking.
It's almost as if we're in Seattle.
Oh, it looks like Seattle out there.
Any more patient stories? Here's Tony King.
Thank you. I just had a question. I don't have a lot of experience in this. You were talking about the motivational interviewing and that is kind of a guide. The only thing I can compare it to is when a person comes to my pharmacy and they want to quit smoking, and I have to kind of walk through it. But at that point, they have at least some motivation. So what kind of success are you seeing when you're the one initiating this kind of conversation or having this with it? I know there's probably not hard statistics on it like we do with smoking, but I don't know how to compare it. I guess I don't know, when you're starting that conversation with someone that really doesn't want to quit, how does it go?
So I've seen firsthand, it's really a function of rapport, and to be totally frank, usually cannabis insofar as the rank order list of triaged issues that patients and I work on, it tends to be kind of the third or fourth at the highest, because so often somebody has perhaps a safety crisis, is dealing with opioid use disorder, methamphetamine use, simply put, forms of substance use that have way higher morbidity and mortality. We're going to focus on those first. By the time we get to cannabis, in most cases, there's sufficient rapport that people are at least willing to listen, and doing the structured, brief motivational interviewing in which you ask someone about what they think about, for example, how they rated their use on a standardized instrument using something out of Espert, and how that compares to other people, and have them reflect on what cannabis gives them, what it potentially takes away, and then ask them directly on a scale of 1 to 10, 1 being no interest whatsoever in cutting back how much cannabis you use, 10 being you'll do whatever it takes to stop using. So long as someone answers a 3 or higher, you can seize on that and say, hey, you just told me it's a 5 out of 10. That's significant. What's the reason your motivation isn't lower? What's the reason your motivation isn't like down at a 1 or a 2? And in doing so, we're helping elicit a change narrative, because the vast majority of us have some degree of ambivalence about a variety of things in our lives. And for folks who smoke cannabis, especially on a daily basis, oftentimes there is some degree of ambivalence. They may not eagerly acknowledge it because of defense mechanisms and the fact they don't trust someone, and they're used to probably being told, don't smoke pot. And they view it as even maybe part of their identity. But if you get them in a more comfortable place and have their language come out, you can oftentimes seize on what they say to say, hey, on the one hand, I hear, cannabis is helping you relax in the moment, yet you're not sleeping well after all. The next day, you're more anxious, your depression is worse. And if you have a history of criterion A trauma, your PTSD symptoms tend to be worse, never mind psychotic symptoms. What would it be like if we worked on a way to help you cut back, say, halfway, and only smoke every other day? I do practice harm reduction. Not everyone practices that, but essentially meeting the patient where she or he is at and their willingness to change, and going from there. Ultimately, it's wonderful if they can entirely abstain. And we'll always try and motivate that through collaborating with the patient. I don't know if that directly answers your question.
Yeah, it did.
And I think too, if you can ask patients, and I don't know what this will do as Montana moves more into the recreational phase of our cannabis use, but jobs, like what type of job do you want? And are you able to pass a test, a drug test? Some employers, you have to be able to pee clean to work. And so I've had patients where that has been their incentive. They really want to keep their job, and they know that they have to be able to provide for that. And so, challenging them to say, okay, how do I help you get clean so you can keep your job? And so sometimes when we make it not necessarily about the cannabis, we make it about their job, right? This is something that you want to have. This is a goal that you want. Sometimes that is a different tack. So I'm not necessarily saying it's about the pot. I'm going to say, gosh, your employer has these rules. You got to be able to pee clean, particularly if they're in like a safety sensitive position through the DOT, where they have to be able to pee clean. So sometimes that's the different route too. I'm like, yeah, you're right. Cannabis is awesome and you should be able to smoke it, but you've got this job. Maybe let's try to do this. So sometimes that can be really finding what motivates them. It all goes back to motivational interviewing. What motivates them to want to make that change?
Thank you.
Yeah.
Great question, Tony. Well, as we don't have a case, we're seeing a lot of black screens. Unless someone else jumps in. So I don't think we're going to go to cold calling. I think we may call it. So this is our second to last substance use disorder 3D echo. Please join us. It's September 1st is the next.
Yep, you are correct.
is the next and final. We'll talk about telehealth in the substance use disorder treatment space.
Yes, and the other thing, we do want to put just a quick plug. We are going to send you a full Survey Monkey that will really talk about the value of the entire series and kind of what your attitudes are about substance use disorder and treatments and things like that. So we can truly evaluate how much you've learned over the entire series. So I am happy, the more comments that you put into that survey link to give us additional feedback, because I know for myself, I found this incredibly valuable, and there's not a session that hasn't gone by with either this one or the perinatal mental health sessions that I haven't been like, wow, who knew? So hopefully we can elevate everybody's practice with these kinds of sessions.
Great. Well, thank you, everyone. Have a great rest of your week.
Thanks.
Bye now.
Bye-bye.